the actual process of surgery.
Mhm.
So you're going in with a very small uh, tool, so to speak, robotically. What happens to the chest cavity?
Mhm.
How do you get enough room to work on top of the heart when you're in there robotically versus opening somebody up?
Great question. And this is what I want to talk directly to your community because we have, well, the first thing we do is we insufflate carbon dioxide inside the chest in order to create the space. So normally our chest cavities are occupied by the organs, two lungs and a heart, and then all the mediastinal fat and things like that around it that completely occupy the space. So for us to get to the heart, we've got to collapse the left lung. And that's easily done. It's not a permanent condition, and it can be uncollapsed very quickly at the drop of a hat. So nobody needs to worry about the fact that we're collapsing their left lung. When you go on a heart lung machine for regular open heart surgery, you're collapsing both lungs, by the way. I always get that question, oh, you collapsed my lung. How's that going to go? I mean, am I going to be okay? And the answer is yes, you're going to be okay because it's a natural thing. So we collapse the lung, that gives us the space. Now imagine your chest with no lung occupying it, that's all the space we need. But the thing that facilitates this operation endoscopically using a robotic approach is something called an endowrist stabilizer. And it's an instrument on a version of the robot that is called the SI. That SI has been around probably now for about 15 or so years, and it's being replaced by the newer system, which came out in 2014 or 2015, called the XI. And the robot that I use for any coronary intervention, whether it's coronary bypass or myocardial bridge or several other operations on the surface of the heart, when I do it with the robot, I use the old system, which we still have at our hospital. Many surgeons don't have that old system anymore. And it's not, and when I say old, I don't mean it's old and outdated. It's a great system. It's actually, in my mind, I like it better than the newer system. And I use the newer system for other types of robotic heart surgeries. But the message that I want to relay is that that system and the stabilizer are not available for the newer generations of robot. And so my ability to do this operation will cease to exist once we phase out completely this SI robot, which will happen probably in about a year and a half.
Mm.
And because surgeons have not adopted this approach, whether it's for coronary bypass or for the other procedures of which bridge unroofing is one of. The company hasn't felt the need to make a stabilizer that can assist us in doing this operation totally endoscopically. And so, because the myocardial bridge community is very active, which I've noticed,
Mhm.
I think that they can be a voice, or you can be a voice in helping industry understand that, some of these instruments are vital to these operations and um, they need to continue to provide them to those of us who are interested. It may not be a huge amount of volume that they're going to get out of this type of an instrument. It's not like prostate surgery that is done robotically,
Mhm.
um, but it is a vital piece of what we do on the heart that if they, when it goes away, I won't be able to do this operation anymore.
Well, what we'll do is once we complete the discussion for the episode, I'll get this information from you. And for everybody, I will share this in the show notes
Mm.
so that we can mount our own cause to say, hey, this needs to continue for a variety of reasons. And if you can let me know the other surgeries it's necessary for besides just our condition of myocardial bridges, that would be wonderful.
Sure.
And we will mount a campaign because we have enough challenges getting cardiologists to accept the fact that our symptoms are real.
Yeah.
We certainly don't need the few that accept that they are real that are helping us challenged.
Truly. Truly.
That's just another consequence we just don't need to have at this point.
Yeah.
You mentioned in one of the videos that I saw on the University of Chicago website haptic feedback.
Yep.
Uh, which is something that you don't get from the mechanics of the robot at this point. Whereas if you were surgically in there with your hands, you could feel the density of the tissue as you were cutting, and you would understand a little bit more by feel. How has that challenged, or how have you accommodated the situation where you don't have that sense of feel that you don't get from the robot?
Yeah. Um, so it's a matter of experience and kind of learning curve, if you will. When you first start operating with these tools, you have no clue how much pressure you're exerting on the tissue, and the cases will take longer because you're still kind of trying to develop your sense of dimensions and tension and pressure and things like that. As you get more and more experienced, you develop what is sometimes called visual haptic feedback. And so,
Hmm.
for example, when I use a very, very thin, fine suture and I want to tie it, I can't really feel the tension that I'm exerting on the stitch or the thread. And so, what I end up doing is using my visualization to understand uh, different cues that generally then will give me the feedback that I need. If I, for example, want to see how hard or stiff a coronary artery is and whether it's calcified or not, I move it around and kind of see how it responds. So even though I can't really feel the softness or the hardness of the vessel, I know how hard it is by just
Hmm.
having done it, hundreds of times. So visual haptic feedback is a thing, and that's kind of what we rely on to help us assess these things. And I think it's even though we don't know that we're doing that, it comes naturally, I believe, and you quickly overcome. Would it be nice to have a haptic feedback system? Absolutely. There are some robot companies that are working on that, but it's not there yet.
Well, I figure if they can get the steering wheel in a car to tell you when you're crossing over the lane by
Yeah,
vibration, I'm sure they're going to get there with AI now and technology
yeah,
for the robot.
true.
What are some of the concerns post robotic surgery that may be different than traditional sternotomy recovery?
Yeah, good question. There's a couple, and they're minor. One of them is the fact that we do, as I mentioned before, use carbon dioxide to insufflate the chest and create the space. That can be sometimes caustic on the tissues, the pericardium, which is the lining of the heart, and the pleura, and that can cause an inflammatory condition with maybe a little bit of a higher incidence of pericarditis, and
Mhm.
that manifests in and of itself of a chest pain, which is different than the pain that somebody would have had before. And we treat that with medication for 4 or 5 days after surgery. Sometimes it's a course of steroids, sometimes it's other medications, anti-inflammatory. So the incidence is, in general open cardiac surgery procedures, if it's about 5%, it may be closer to 10% here, but it's not a high number.
Mhm. And of the 40 patients roughly that you've done so far for bridge repair,
Mhm.
how many of them have said they experienced significant improvements in their capabilities or significant decreases in their pain or symptoms?
82.9%.
Wonderful. And I would imagine the other 18, 17% has probably got some comorbidities or other issues that are
Yeah.
plaguing them.
Yes, exactly. And that's, I think, as we're getting more experienced and we're learning, a function of better selecting the patients. And, patient selection is a word that you hear a lot in the medical literature and people who present their results. And to me, medical selection is like I would love to say to you, 99% of our patients have excellent improvement in their pain. But what it means is that I've excluded a lot of patients to get to that number. So
Hmm.
in this case, I've included 17% that may or may not have had a positive um, result. Uh, and unfortunately, they didn't. But we may have, in that process of decreasing our threshold, have included another 15% that did.
Right.
There's this notion in general surgery that you have to have a certain percentage of what they call negative laparotomies, which means you have to be able, and this is in the treatment of appendicitis, in which we know is a terrible disease and it's a very easy fix. You get your appendix taken out if you have it inflamed. And so there are some patients who come in with belly pain in the middle of the night, and you just can't be sure. And so you got to take them to the OR. And you take them to the OR, and you find that you have what they call a negative lap, meaning the appendix is perfectly fine and it's not inflamed, and you didn't have to take them to the OR. But in order to get as many appendicitis, which is a terrible disease to be left alone, you've got to have some negative laps. Does that make sense?
Mhm.
Yeah,
Absolutely.
yeah. And so if we were really, really selective, and I am very selective, as I mentioned before, we'd have a success rate of 99%. But we don't, and I think it's okay.
And we do see people who have gone through the opportunity of submission to surgeons who are doing robotic surgery and get declined. And clearly, there are other issues that the surgeon is looking at, saying, this just isn't going to work for you.
Yeah.
And I think that's the best thing you can do, because to have that false expectation of improvement is worse than understanding that you have some complications that may require a sternotomy, or you may have other situations where you may not even be a candidate for, the unroofing procedure. And
Well, I want to
it,
explain one thing is that when people get denied robotic myocardial bridge unroofing,
mhm,
in my practice, it's not because there are technical difficulties or that it cannot be done robotically, but I can do it with a sternotomy. That is not the reason that they get declined. The reason they get declined is because we don't think that they would benefit from an unroofing procedure because of their symptoms being not perfectly aligned with what this disease does, or because their angiographic interrogation, what we call provocative testing, is not positive.
mhm.
From the technical aspects, there is not a myocardial bridge that we can't handle robotically. It's not like we need to do a sternotomy because of this or that or the other. Um, when you're experienced at robotic surgery, then you can handle pretty much the majority of bridges, all of them. Indeed, the robotic approach allows you to do a more extensive, sometimes myocardial bridge unroofing than a non-robotic approach.